please keep your microphones off as well. Thank you.
Thank you very much, Dr. Chaturanga. At the outset, I would like to thank the President and the Organizing Committee of the Kandy Society of Medicine for giving me this opportunity. Let's talk about very important topic, as Dr. Chaturanga said, managing dyslipidemia. So in my talk, I will mainly discuss the sorry about that small interruption. So the outline of my lecture is I described on epidemiology, introduction of lipids and lipoproteins, the rationale of treating dyslipidemia, and the main part, the treatment of dyslipidemia, timing and the target. So the epidemiology, we know that dyslipidemia is one of the major cardiovascular risk factors that leads to atherosclerotic cardiovascular disease, that we commonly call it as ASCVD. So we know that ASCVD causes 14 million deaths annually, and we expected to rise more than 25 million by year 2025. And interestingly, that intervention could prevent more than 500,000 deaths annually. So you can see this the chart. We can see the cardiovascular diseases, the ischemic heart disease and stroke are the main leading causes of death in 2000 as well as 2019. So let's move to the dyslipidemia now. Dyslipidemia is characterized by abnormal levels of certain lipids. The cholesterol and triglycerides are the major lipids that transported in plasma as lipoproteins. So this is a lipoprotein, the molecule that you can see that lipoprotein is actually combined with the proteins and the lipid. The core is the triglyceride and the outside there are cholesterol particles as well as these are protein particles which is called apoproteins. So this is a classification of lipoprotein. You can see the largest particle, the lipoprotein is the chylomicron and the chylomicron remnant. Then we have the very low density lipoproteins, intermediate density lipoproteins, LDLO, the low density lipoproteins, and the HDL, high density lipoproteins. If the size of the lipoprotein, if it is less than 70 nanometers, they can actually penetrate the endothelium and causes inflammation and atherosclerosis. So other than the chylomicrons, all the others can penetrate and can cause atherogenesis. All these are other than the HDL can cause atherogenesis. That's why they are called bad lipoprotein, whereas the HDL is the good or the lipoprotein. So with regards to lipoprotein metabolism, I said that the lipoprotein is rich of the triglycerides and as well as the cholesterol. So actually the blue color is the triglyceride part and the pinkish one is the cholesterol. So this chylomicron, when it is absorbed from the gut, then by lipoprotein lipase enzymes and the free fatty acids are removed, then it is called the chylomicron remnant, which is again rich in triglycerides. Then it's taken up by the liver, will produce VLDL, again rich in more triglycerides than the cholesterol. Then more fatty acids are removed, then it becomes ILDL, and when more and more free fatty acids are removed, then it becomes the LDL. So if you see this LDL, it is more cholesterol than the triglycerides, whereas the VLDL is more triglycerides. Hope that you have understood about these lipoproteins now. So let's look at again the lipoproteins. That I have actually all the lipoproteins are here. And if you see this LDL, and there's another category called lipoprotein small a. And when you check the lipoprotein LDL-C in your lipid profile, this is both LDL and lipoprotein small a is actually combined for this LDL-C. Whereas the VLDL and IDL, we know that they are atherogenic triglycerides rich lipoproteins. And all these four things together, other than the HDL, is called non-HDL. These are all atherogenic lipoproteins. Other thing is make note that there's a ApoB as in all the lipoproteins. Hope that you can remember that I could not tell actually. That's this small particle on top of these are apoproteins. So dyslipidemia characterized classified into genetic as well as a secondary. I'm not going to discuss this in detail. And the secondary causes that we know that hyperthyroidism and the nephrotic syndrome causes high cholesterol. And the triglycerides are the causes again the hypothyroidism, the obesity, chronic kidney disease, the alcohol, and there are medications as well including thiazides. However, this classification, at the more than the classification, dyslipidemia is a more or less complex and combined disease. And for that, the genetic, there's actually diet part as well, and the insulin resistance, metabolic syndrome, diabetes, everything combined together is called the increased atherosclerotic risk. So, important thing is the cardiovascular screening. So, routine screening, very important to get the history and examination related to the cardiovascular risk factors and the cardiovascular disease. And then investigations like then the examination that you have to check the blood pressure, then the other important thing related to CVDs. And the investigations wise, ideally you have to arrange the lipid profile. If the facilities are not available, you can do the total cholesterol initially, which has what's the ministry recommended in the above all the patients above 35 years that we need to do the cardiovascular screening. And the blood sugars, the fasting blood sugar, HbA1c, and the serum creatinine and the EGFR is very important to exclude the chronic kidney disease. Do we need fasting lipid profile? The guidelines do not recommend actually the fasting lipid profile to assess the cardiovascular risk. So, however, that is very convenient to the patient because you can ask the patient to come at any time and give the blood lipid profile. However, when you do the random lipid profile, if the triglyceride is more than 400, then you need to do the fasting one to assess the triglycerides well as the LDL, because we know when the LDL is triglycerides more than 400, we cannot get the LDL value. There are other risk modifiers as well, though we do not do all these things commonly, but you should know. The other cardiovascular risk factors are obesity, metabolic syndrome, non-alcoholic fatty liver disease, and also other inflammatory conditions such as rheumatoid arthritis, even the psychiatric disorders. The other countries, they do the arterial, carotid or femoral plaque burden by doing the duplex Doppler to assess the patients whether they are having atherosclerotic disease. And thus by the calcium artery, coronary artery calcium score by doing the CT coronary angiogram. For us, of course, the facilities are not available. Do them as screening, remember. And the lipoprotein small a as well as ApoB protein are also recommended in the guidelines in other countries. But I will discuss them in little more detail. The lipoprotein, the small a, is the LDL-like particle. Hope that you can remember. That's highly heritable and autosomal codominant as well. More or less same value throughout the life. So what the other guidelines recommend, do it just once in a lifetime to assess this level. Because this is important because it has a lifetime risk of atherosclerotic cardiovascular disease equivalent to the risk associated heterozygote familial hypercholesterolemia. And important, exclude the causes, other secondary causes before doing this analysis because this is somewhat expensive. It's around now 9,500, like the hypothyroidism, the chronic kidney disease, and even the nephrotic syndrome, that you have to exclude these causes before arranging this. So the other guidelines do, although they do recommend this as a routine thing to do, but the Heart UK consensus statement, they suggest to do only in the patients who are having family history of premature atherosclerotic cardiovascular diseases, or if the first degree relatives having the high lipoprotein assessment, and also familial hypercholesterolemia or other genetic dyslipidemias, or if they are having the calcific aortic valve stenosis, and if they have the moderate CV risk. Why it is important? If the patients with our calculation, CV risk calculation, if they have the moderate risk, if we do this, if this is high, that we can make them as a high risk patients and start treatment accordingly. So for us, of course, I think these two are very important. The family history of premature atherosclerotic cardiovascular disease, and also if they are having a moderate risk, you might consider doing this test in affordable patients. So the other test is ApoB analysis, and this represents an estimation of all atherogenic lipoproteins. As I said earlier, VLDL, IDL, LDL, and all the lipoproteins small a. The atherogenic dyslipidemia, we know there is overproduction of VLDL as well as the ApoB. So this is recommended for risk again enhancer in a intermediate or moderate risk patients. So this is again especially important in patients such as they are having high triglycerides, or if they are having diabetes, obesity, metabolic syndrome, or again if they have very low LDL-C. Now we come to the management of dyslipidemia. So the primary target is the LDL reduction. Then after having this LDL target, then you have to concentrate on non-HDL as the second target of therapy. In this situation, we might reduce the triglycerides as well. However, we don't go for the targets of the total cholesterol as well as the HDL in the guidelines. So there are many guidelines. ACCHA in 2018 and ESC guideline in 2019 and the Canadian guidelines 2021, and there had been other guideline, our national guideline. Actually, this is done by the Ceylon College of Physicians together with the NCD unit of the Ministry of Health in 2021. Yes, to publish. The draft version is available. So then you talk about the management of dyslipidemia, the lifestyle changes as well as the drug therapy. I will mainly concentrate in this topic today is the drug treatment. So under the drug treatment, main things are the LMG CoA reductase inhibitor, that is statin, we commonly know, and the cholesterol absorption inhibitor, that is ezetimibe, and the PCK9 targeted treatment. And for the triglyceride reductions, the fibrates, omega-3, and the fibric acids, of course, nicotinic acid we don't use commonly. However, whatever the pharmacological management of any dyslipidemia, the first drug is the statin. Remember that. So each 1 millimole a reduction of LDL-C with statin will reduce the major cardiovascular diseases, major coronary events, the cardiac deaths, total stroke, total mortality by significant number percentage. You can see. So this is very important. 1 millimeter reduction will reduce this much of the risk. So there are some clinical trials as well. You can see some major trials done with using the statin will actually again reduce the coronary heart disease event reduction by the significant number of again the percentage. So the other thing is the statin, the last decades that shows that the LDL lower is the better. You can see when the LDL when it comes lower and lower, the coronary heart disease events also will go lower and lower. So this is very important. Lower is that is better. We'll come to the discussing now about the statin. Statins will reduce the circulating levels of LDL cholesterol by decreasing cholesterol biosynthesis and VLDL secretion from the liver, and also the clearance of the LDL particle from the circulation. Not only that will reduces the LDL, that will reduce the plasma triglycerides also by about 15 to 20%, and also increases HDL, that is good cholesterol, by 15%. So the statins are important as a drug in this dyslipidemia management. So what statin to use? That is actually driven by the absolute LDL reduction. So use a suitable statin with a low cost. So this is actually 3 statins are displayed here, and remember that we are mainly concentrating in the management of dyslipidemia, moderate to high intensity statins. And the only two drugs that we use nowadays, the atorvastatin and the rosuvastatin, as the component of high intensity the part, because it can reduce the LDL by more than 50% from the baseline. The atorvastatin 40 to 80 and the rosuvastatin 20 to 40 can do that LDL reduction more than 50%. This is called high intensity, high dose statin. That's how we call it. And for the moderate intensity, that's a reduction of LDL by 30 to 49% with atorvastatin 10 to 20 and the rosuvastatin 5 to 10. Simvastatin, no high intensity part. So because of that, we don't use it. Decisions to start statin depends on the cardiovascular risk and the LDL level. So why this cardiovascular risk assessment is important? Cardiovascular risk is the likelihood of a person developing atherosclerotic cardiovascular event over a defined period of time. We usually take it as a 10 years. There are 2 methods of checking this. The first method is the general estimation of the relative number of cardiovascular risk factors. You can count the number of major cardiovascular risk factors that the patient is having. The other one is the absolute risk of doing the cardiovascular risk assessment by using the risk assessment tools or charts. This is important because by this that we can identify the patients who are actually having high cardiovascular risk, and we can reduce the cardiovascular risk by intensifications of all treatment modalities. And also we can avoid unnecessary use of statin in low risk patients. That is again important. If you take 2 patients, the one female with 50 years who are having LDL 130 without diabetes, if you check her CV risk is less than 10%, but if the patient is having diabetes, risk is definitely high. She needs statin. So because of that, you need the risk assessment to pick the patients who are having high CV risk, and also to avoid unnecessary use of statin in low risk patients. There are many CV risk calculators, but for us what is recommended by WHO is the WHO and ISH risk calculator. That is a chart actually. So you can see the Sri Lanka also there for the Southeast Asia. And though this is actually, there's no app for this, so we need to use this chart. Probably you have seen that you have used. And for this we need the blood sugars as well as so patients with diabetes on this one side, and the non-diabetes, whether they are smoke or non-smoke, whether they are male or female, like that. Then we need identify the age category, blood pressure, and the cholesterol level. Then we go for the CV risk, the box. So anything above the 20% is called high risk. Red or maroon is high risk. Green is low risk. Remember this. So there's a non-laboratory based thing. We don't need to check the blood sugars and the cholesterol levels. We can go with the BMI and check it. So, which patients do not need CV risk assessment? Because they are already having high cardiovascular risk. Because of that, you don't need to check their the cardiovascular risk assessment. If they have already having established cardiovascular diseases, and if they have familial hypercholesterolemia, chronic kidney disease stage 3 or above, and the type 2 diabetes, if they are having target organ damage, for example microalbuminuria, if they have the multiple cardiac risk factors along with diabetes, and if they have the long duration more than 10 years, that you don't need to check the CV risk, already their risk is high. So if they have the elevated single risk factor, they are having the total cholesterol more than 310, LDL more than 190, and the blood pressure more than 180, 110. So if any patient is having any of these things, they are having high CV risk, you don't need to check the CV risk calculation. The indication for statin, the primary or secondary. The primary prevention, that's a patient who has not had any cardiovascular diseases previously, but having conditions with a high CV risk, which I have already discussed. And if they having any the risk calculation, if the CV risk is more than 20%, that, or even though they have not had previous CVD, you need to start statin to reduce the cardiovascular risk. That's the primary prevention. Secondary prevention is they are having the clinical atherosclerotic cardiovascular diseases, ischemic heart disease, stroke, TIA, peripheral artery disease, or previously the revascularization. And these categories of patients actually need, these I have listed only the clinical ASCVD, but other patients also, if they have undergone the CT coronary angiogram, if they have the plaques by doing the carotid Doppler also, that we can consider those patients also. They need high dose, high intensity statin. So what is the target of these patients? So secondary prevention, that if they have already has any cardiovascular diseases, they are having very high risk. So their target is less than 55 LDL target. So if they have what do you mean by extreme risk? So patient who has had a myocardial infarction the 2 years ago, last year, if they had got another cardiovascular event, for example stroke, then the two territories are involved, then the patient is having the extreme risk. So they need the LDL reduction less than 40. Remember, so if your patient is having the 2 arterial involvement, consider reduction of the LDL to less than 40. For the primary prevention, the high risk patients, if it is more than 20%, target is less than 70, the moderate risk less than 100. Even for low risk patient, it has to be less than 116. That this is from the ESC guidelines. This I'm not going to this ESC guideline. They have nicely discussed about the high risk conditions and the very high risk, moderate risk, and the there's low risk and their targets as well. I advise you all to go and read this. And these are the very high risk conditions and the high risk conditions which the guideline discussed. So if the patients with very high risk need less than 55 the LDL target, high risk the patients need less than 70. So what about type 2 diabetes in the primary prevention? This is again important. The high intensity statin need in the diabetes patients with multiple cardiovascular risk factors, or if they have the 10-year risk is more than 20%. So you can give, that is in these patients that you need to give atorvastatin 40. If you are giving atorvastatin 20, 40 to 80, I mean if you want to give. So we always started atorvastatin 40 and then consider increasing it further later. The moderate intensity statin that you can give in the patients who are above 40 years, or even if they're younger than 40 years, but if they have additional cardiovascular risk factor. So if they have the 10-year cardiovascular risk is between 10 to 20%, again that you have to give a moderate intensity statin, that atorvastatin 10 to 20 with rosuvastatin 5 to 10. So what is the LDL target in diabetes? If they are having very high risk, target again less than 55, diabetes with target organ damage. So if they have the microalbuminuria, that is adequate for you to consider to keep the LDL less than 55. So if they have the multiple risk factors, or if their diabetes is more than 20 years, you can straight away get the target to this level. And the high risk patients, diabetes more than 10 years, diabetes with the one additional risk factor, that is less than 70, and for the moderate risk is the less than 100. So all the diabetics should be, their target should be less than 100. Remember that you need to give at least a moderate intensity statin for all the diabetics, unless they are having a very, very low risk. So what about the patients who are elderly populations above 75 years? If they are already on statin, you may continue it. At the same time, or if the patient has had the major cardiovascular disease, that you can start statin. But at that situation, you can start with a little lower dose, maybe 20, and that you can up titrate gradually. And otherwise, routinely in patients, you don't check the lipid profile in above 75 years, because if they can live up to 75 years, I mean, you don't do the risk assessment. Routinely, the guidelines do not recommend unless they have the high CV risk already. The age, if it is 20 to 39, that there are actually no randomized controlled trials on these categories of patients. But you can always check the lifetime risk and consider the statin if they have the family history of premature cardiovascular diseases, and also if their LDL is with the LDL more than 160. Remember, this continuation of statin is very important. The statins should be increased to maximum tolerated dose to achieve the treatment targets, the targets which I have discussed. And once the target is achieved, statin should be continued in the same dose. Because what we commonly see, that we are doing the lipids not to reduce the dose, just to further increase of the statin if it is not getting the target. But what is commonly happening in our clinic settings is that we look at the lipid profile. Then not only the patients, then the doctors also do get alarmed when they see the low LDL levels. Then they reduce the statin. Then the patient do comes in the next year or earlier than with another cardiovascular disease. So I request you all, do not reduce the statin dose if the patient has been started statin for the high CV risk. Follow-up. Repeat the lipid profile in 12 weeks. So usually, you can do it in 3 to 4 months later. And after starting the statin, and then also after increasing the statin dose. Intensify statin to maximum tolerated dose to achieve targets. So once achieving targets, repeat the lipid profile that you can do in 3 to 12 months. Obviously, we cannot repeat nowadays. So if your patient is, the practical what I am saying, if the patient is not having the cardiovascular diseases and also your patient is having a good compliance, and if their last LDL within the satisfactory target, that you can do only the once a year annually. Okay, not frequently. That's because we don't have that much of resources in the hospital nowadays. So don't do unnecessary lipid profile in the patients unless it's really indicated. So what are the side effects of the statin? Actually, statins are well tolerated, and all these side effects which I have mentioned are actually rare. The SAMS is statin-associated muscle symptoms, the myalgias. In that situation, CK is normal. Again, only in 1 to 5% of patients. Myositis when the CK is increasing. Again, rare. Rhabdomyolysis with the when the CK is about 10 times with the renal injury. Again, it's rare. So these are, though this mentioned, it's actually rare. You don't have to worry about these things. You can always start statin if it is indicated. And the liver side effects, rising of the ALT more than 3 times upper limit normal is again infrequent. Liver failure, very rare. Usually the statin won't cause liver failure. They usually initially can go for the little transaminitis, but again it comes to the normal levels. So you don't have to panic when there's little rise of the liver enzymes. So very safe in regarding the liver. We know that even for the non-alcoholic fatty liver disease, that we give it as a treatment. So you don't have to worry even the liver enzymes are high, unless it's more than 3 times the upper limit of normal. So in new onset diabetes, it has been recognized, but is again very rare. The benefit is more than the risk. Number needed to read is one case of in 225 over 4-year treatment, and always encourage lifestyle changes for them not to develop diabetes. So other side effects such as memory impairment, the cancers, low testosterone, and hemorrhagic stroke, that's actually not proven. So statin, again safety recommendation. So you can do the baseline ALT before starting the statin. Then you will repeat the ALT after 2 months later, and the routine monitoring thereafter is not recommended. So if it is less than if the ALT is high but is less than upper limit of 3 times the upper limit or normal, continue statin, but you may monitor liver enzymes. But if it is more than 3 times the upper limit of normal, you can temporarily withhold and monitor liver enzymes. If when it is normal, you can start with a lower dose, or you may use another statin and see. Or less is encouraged to restart statin in the patients who are in high risk. And if it is persistently there even after stopping statin, it could be other reasons for that elevation of the liver enzymes. So CK, baseline CK is not recommended before starting treatment unless the patient has symptoms. So if the CK becomes elevated more than 10 times the upper limit normal, then you can stop and you can recheck the CK every 2 weeks. And if it is less than 10, you continue if the patient is asymptomatic. But if the patients are symptomatic, and stop and monitor CK levels. That's a recommendation given. So what about the statin in pregnancy and breastfeeding? You need to avoid, remember that. And all the childbearing age, if they are planning for pregnancy, don't start statin. and during pregnancy as well as a breastfeeding. So what will happen? What are the recommendation if when the statin is you have increased the maximum tolerated dose, and but the still the LDL is not having the therapeutic target. So there are drugs like ezetimibe cholesterol absorption inhibitor, and that PCK9 inhibitor still not available, evolocumab and evolocumab, and these are very potent drugs. Actually will reduce the LDL by more than 60%, and also increase run, and again it's reduce the hepatic the synthesis, and both these actually have to give as subcutaneous, so it's somewhat difficult, and remember these are very expensive drugs. I don't think we can use. Bempedoic acid is another one. Still we have the ezetimibe. So if it is not getting control, you can start the ezetimibe in our patients. So these are two trials. This is for the PGs, for the Odyssey and the Fourier, for the PCK9 inhibitors. You can go and read. So this shows that even the very low levels, less than 40, the patients are tolerating them very well. They have identified only the injection, the associated side effects only during these two trials. So next target is the non-HDL cholesterol. So we know that non-HDL is cholesterol minus is the HDL, and for all the atherogenic lipoproteins that we have to consider, including the LDLs, once we achieve the target of LDL, then we have to concentrate mainly on the VLDL and the LDL and the chylomicron remnant. So in this situation, we have to control the triglyceride level. So triglycerides, so if it is very high, that without any, if it is very high above 500 anyway, you need to think about the pancreatitis, all the risk that you need to control it, and also look for other causes in that situation. And if it is triglycerides between this range without any low risk, again the lifestyle changes and the drugs are not recommended that during this for these levels. But if it is more than 135 499 with a high CV risk, again to start is the first drug as the statin. Then if it is not under control with the statin, then add in omega-3 high doses. That EPA high doses, 2 gram BD is recommended, not the fish oil dose that we start. Okay, so however there's no overall the total mortality reduction using this omega-3 according to the available evidence. So if it is not again getting the target, that you can start the fenofibrate next. So this about omega-3. There are 2 trials done with the reduce it trial with this PUFA high dose, and this vital trial has shown the low doses are there's no benefit. So in the South Asian, we do have atherogenic phenotype. We have low HDL, high triglycerides, moderate LDL-C, elevated non-HDL-C, and high levels of small dense LDL particles, and the elevated the ApoB, and also high lipoprotein A levels. So do not think that we are having the same risk as like our Western counterpart. We have more risk than them. We have all the atherogenic, this thing with the atherogenic phenotype. So that's the last thing on the medication. So the therapeutic lifestyle, I'm not going to discuss this in detail, though I want to discuss because it's very fun topic of mine. Weight reduction, the increased physical activity, and the healthy diet, and the smoking cessation. If you have any questions, I'm happy to answer. So we'll discuss one case, and I am going to end my talk. This is Mr. Pereira with 68 years, diabetes and hypertension. For 5 years, he has a recent acute coronary syndrome, treated with atorvastatin 40, and his lipids 4 months later is LDL 50. So what do? You reduce atorvastatin to 20, reduce to 10, and continue the same dose for the atorvastatin 40, and add omega-3. So you know the answer now. As you continue the same dose, we have achieved the target, less than 55. And hope that you can remember this after secondary events, then 55. So, Mr. Pereira, again, that you have continued the same dose, the statin, his compliance is good, lifestyle changes are good, and LDL remains 55, that he developed stroke 1 year later. So, what is your LDL target now? Less than 40. So, what do you do now? So, you increase atorvastatin for 18? Yes, you can try that. If the patient can tolerate, you can try that first. That's what the guideline says. And if it is not tolerating, you may add ezetimibe and get the control along with the lifestyle changes. So my take-home message, this is the cardiovascular risk and also the category, and know the baseline value and know the guideline recommendation. This is very important. Don't just treat patients as it is. Do not reduce statin when the LDL improves in high-risk patients. The lifestyle changes and the risk factor control is very important. Thank you.
The mic. So, could you have any questions? It's time to ask.
So there are many brands of statins in the market. Are there differences in these brands? There are cheaper brands, there are expensive brands.
That of course, I don't think I'm a suitable person to answer this question because I don't I don't do any private practice. So the people who actually use the brands, I think they are more suitable to answer these questions. Anyway, the statins has a class effect, so you can use it and you can see with 2 different statins and assess and see. That's a simple answer that I could give.
That's why you are very no. Do you know whether there's any head-to-head comparison with atorvastatin versus to rosuvastatin versus to simvastatin? In terms of the efficacy-wise, what is better?
Head-to-head trial, of course, I don't think they have done any. And but I think efficacy-wise, always as rosuvastatin is better because they have done mainly the rosuvastatin recent trials. If that is efficacy-wise, is more potent. Anyway, simvastatin now we don't use nowadays because it has only the moderate intensity effect, not high intensity.
Any other questions?
No one is having any dietary issues, I hope.
No, I'm asking this. Statins, do they interact with alcohol consumption?
No, it's not proven, but only thing the both will affect the liver. When you start with the high dose, the alcohol is you have to always, when you take alcohol, that you have to use the recommended alcohol quantity. But if you take it alcohol above that, that can definitely damage liver, but by not statin. But on top of that, if you give the statin, that the bad effect will come to statin, but not to alcohol.
Management of the
With regards to actually the diet, mainly you need to control the saturated fats and also to trans fat. What I say is trans fat, all these the bakery items and the deep fried foods. Actually, it should be less than 1% in your diet. So what I advise is always do not eat this the fast food, because what is the cook at home is much better. Again, don't deep fry. You can stir fry, but don't deep fry. So saturated fat, again, the I encourage all to eat one egg a day, because that will not increase your cholesterol, because your cholesterol requirement is 200 milligram only, 300 milligram, because only our egg has the 200 cholesterol. But as far as if you don't eat too much of these cheese, butter, and the meat products, which has again the high saturated fats, you can use this one egg a day, which has a very good nutrients, which will increase the omega-3 fatty acids, and also very good high quality protein. So don't scare to take one egg a day, because we know that Queen Elizabeth, she ate 2 eggs per day and she lived up to 90 years. So if the eggs causing any bad effects, she would have died long time ago.
I thought you were going to tell that Queen Elizabeth can only eat eggs today.
King Charles is not interested in Queen Elizabeth anymore. Really, thank you for that very interesting talk. Regarding diet, there were some studies which show that dietary modification does not alter the cholesterol levels are mainly based on a genetic imprinting rather than the diet. So, and then
Yes.
the other thing is along with that only they said even eggs without any limitation
Yes,
you can take.
that's the
That's one this thing. And then
yes.
coconut and cholesterol, any latest updates that you have?
Because coconut again has a high saturated food, because anything you can't take too much, because we used to eat a lot of pulsam oil and all that. I advise you all not to eat pulsam oil. Again, when you eat, better to eat the unrefined carbohydrate as much as possible, because if you refine anything like for the bread, whatever thing, we go for the kurakam bread and other things. But I advise to eat rice for all 3 meals, because if you eat rice, we can add lot of fiber, green leaves and other things. But if you eat the bread and other thing, can we eat with that? What we eat with the one the either pulsam bowl or one hoti kind of thing. So one gravy with again rich of the coconut milk. So it's always eat rice with lot of the green leaves and available vegetables, not carrot, beans, and all this expensive item. We have adequate number of vegetables in and around which we can get, and we can eat all 3 meals rice, because rice has very good source of protein. Sri Lanka is 50% of protein actually by rice. Sri Lankan people. So I mean, do not advise to the cut down their thing, and even the other the green grams and other cereals you can advise. But again, it's good if they can get another the fiber also into the breakfast. But again, if it's otherwise, if it is carbohydrate and the protein only, so they can do some rice. If they eat rice, they will get some the vegetables also. So other thing is that all these the cereals are now very expensive, so I don't think even we can afford to eat very expensive. So our people still can eat rice, unrefined rice with lot of vegetables and available vegetables.
So, just a little comment about since we have started with the diet, because the largest clinical study now was published in 2017. That's a peer study. So, see, it's really we are encouraging with our rice, but the fact that the study shows those who are in the diet containing the energy from 60% energy from carbohydrates, that water weight is very high. So keeping in mind, carbohydrates and fat both cardiovascular and non-cardiovascular death. The second thing is the same study. So we have a bit of the fear on the bit of a fat, because that study shows a really saturated fat or with a quite safe. In fact, 24 reduction of a bit of a stroke. So that's the study. Second thing is that probably unfortunately that study not analyze the our trans fat. So when you are talking about the fat, I think that as we say, this is the bad or this trans fat. Unfortunately, some Asian countries seems to be the number one killer trans fat. Without your knowledge, so we are consuming a lot of amount of trans fat. Recommendation is to get the 2 gram per day from the natural food, and that is taking most of the bakery items. So probably they are contained the popular trans fat, unusual amount. And some states our school children. So for the one spread, the recommendation 2 gram, 14 gram or 16 gram for one spread. So our younger generation, we are exposing very high dose of trans fats. It seems to be the high epidemic excellence attached with the apoprotein the lipoproteins that probably the endogenous, highly endogenous side. If you were the one factor, the extent, it's a trans fat. Very unfortunately, in our part of the country, it's not highlighting. We are highlighting smoking and the other risk factor. It's probably not talking about the trans fat. In the supermarkets, a lot of trans fat available. So in the diet, probably I think other than the carbohydrate, maybe the trans fat, maybe the number one killer in some Asian part of the country.
Yeah, I totally agree with you. What I said about our people do eat lot of rice. That's the only issue, because we have to get the calorie from the thing rice. I said not from the refined carbohydrate, but that's what I said. But otherwise, don't eat too much of rice and think that will cure everything. So what I said, don't use the refined carbohydrate as the carbohydrate source. In that case, use the rice.
Excuse me, do they recommend particular time frame to assess the efficacy of each of these different statin drugs? I mean, once you start, let's say, once you start statin, and how long that you are, keep on going to check whether its efficacy is there, and
Yeah.
if you really wanted to change it.
Yes, the first thing that you can do is the first sample you can do after starting in 3 months time, 2 to 3 months later, and then depending on your availability and the hospital availability, that you can repeat every 3 to 12 months. But what I said is nowadays we don't have that much of resources that we can, depending on the patient risk, that we can decide when to repeat one. But you would definitely assess the lipid profile again to see whether we are keeping on the same target or not. That's very important.